Welcome to this session on evaluation and management of poorly differentiated anaplastic and aggressive variants of thyroid cancer. I'll just, before we get started, I'll reiterate what you've heard several times already. First of all, a sincere thank you for coming to what has turned into a wonderful meeting. We appreciate your feedback, so please tell us what you liked, tell us what you didn't like, especially because we will be doing this again right here in Boston in 4 years, and we want to continue to make it better. So your feedback is tremendously appreciated. We are in for a treat for the next 79 minutes and 12 seconds as soon as I get off the podium because we have truly a world-class panel of multidisciplinary thyroid experts for this session. Dr. Smallbridge, Bible, Ferris, Sang, Brose, Zaffario, and Peter Sato right here from Boston. Representing across-the-board experts in all their disciplines in this disease. And what we'll talk about is some aggressive examples of thyroid cancer. We'll also cover the spectrum of the disease all the way from poorly differentiated to medullary to some cases of anaplastic. And the way that we'll do it is we'll have each individual present their case, and then we'll discuss it as a panel. There are microphones in each of the aisles, so if anybody wants to ask a question about the case to any of the panelists, make a comment, I would encourage you to get up to a microphone and do so. So without wasting any more time, Dr. Smallbridge, you are up first. Thank you.
Well, I appreciate the invitation to participate in this symposium, and my job right now is just to present very quickly a case. Those of you who were in the anaplastic session immediately prior, a small number of you were privy to seeing this. We focused on one aspect of it, but Dr. Cohen told you what we were going to be talking about, and it's all covered in this one case, actually, all but the medullary. This is an 82-year-old gentleman that I saw fairly recently. Prior to coming to our clinic, he developed a rather rapid onset of a right neck mass, had an ultrasound that showed a nodule. Fine needle aspirate done elsewhere was suspicious for follicular neoplasm. He had no history of radiation exposure, negative family history of thyroid malignancy. On physical, he had a 5-centimeter mass confirmed on ultrasound to be multinodular. The pathology was quite striking. It was 7.2 centimeters, had positive margins as well as extrathyroidal extension and widely invasive lymphovascular invasion. And our pathologist indicated that it had multiple histotypes. 60% of it was felt to be poorly differentiated or insular. 35% of it was differentiated and had elements of classic papillary, follicular, and oncocytic, and 5% of it had focal anaplastic thyroid cancer. And this is just a nice pathology report that Dr. Cortez did for me last week, showing the various elements. And here I think you can see the progression. If anything goes from differentiated through poorly differentiated anaplastic, this illustrated it in this one patient. So after surgery, a PET CT was done to stage this, and he had hypermetabolism in his thyroid bed. He also had a renal mass, and there were many PET negative micronodules in the lung. The largest was 6 millimeters. Because of the renal mass that was detected on CT, the MR of the abdomen was done. It was 4 centimeters, felt to be most consistent with the renal cell carcinoma. We had a few days to do investigations while determining what his postoperative course would be. So we quickly did an I-123 whole body diagnostic scan, which showed uptake in the multiple pulmonary nodules. The question was, were these nodules anaplastic carcinoma, which would immediately stage him as stage 4C and substantially change recommendations for management? Or were they part of this larger differentiated or poorly differentiated tumor? And it appeared that it was differentiated enough to take up iodine, so we quickly gave him recombinant TSH and a dose of radioiodine, and there was uptake in his pulmonary metastases, but not in his kidney. The two previous lesions I've had in the kidney from metastatic thyroid cancer actually were mets from the thyroid cancer, so we're suspecting this is probably not thyroid. Our urologist appreciated the urgency of this anaplastic component to his thyroid cancer and said, well, the kidney cancer could wait for 3 months and they'd reevaluate. And he was seen by our multidisciplinary head and neck clinic, which includes radiation oncologist, medical oncologist, and surgeon, and it was felt that he should have adjuvant IMRT, which he did have, and it was during that preparation that he got his radioiodine. Discussion of weekly chemotherapy was discussed with the patient. Although he was 82 years old, he was extremely robust and physiologically at least 10 or 15 years younger. Nevertheless, he declined chemotherapy. And here you can see the radioiodine scan showing multiple pulmonary metastases. So that's where we stand with this gentleman. He's fairly new. We just finished his treatment. He got through his IMRT with some expected side effects, but he didn't need a feeding tube. He's back eating now, and we're discussing what to do next in terms of adjuvant therapy, and be interested in hearing what our panel and others in the audience think we ought to be doing.
So let me, so thanks, Robert. Let me turn first, Peter, what do you think of the pathology in this case? Is this something that you've seen, and do you care to comment?
Well, I'd like to say that it's a classic, but it's not. It's actually really complicated pathology, and unfortunately, I just got progressive lenses, my glasses, so I can't see. So I was looking at these very small 5 histological panels, trying to quickly figure out what I was looking at to see if I believed it or not, because it's kind of an unbelievable case. And sometimes distinguishing between a poorly differentiated thyroid carcinoma and an anaplastic or undifferentiated thyroid carcinoma is a little bit of an objective threshold call. Now, there are certainly morphological factors and descriptive factors we use to make that differentiation, but certainly there is some disagreement when trying to make that call, and that's kind of irrelevant to a certain extent. Having a well-differentiated oncocytic or Hürthle cell carcinoma present concurrently with a well-differentiated or classical type papillary carcinoma is pretty much unheard of unless it's a collision tumor. So then the situation ends up occurring. Would you want to differentiate between these areas of tumor in terms of trying to say, is part of it BRAF positive and is it clearly classical papillary, or is part of it some other mutation present in the tumor? And of course, that might be useful in an academic perspective, but we don't really care. We know this person has a really bad cancer. So then the question is, what was the evaluation of this tumor surgically? What happened? Was it easy to excise? How much was able to be left in the bed? And sort of what were the margins looking like for us to be able to sort of make next questions?
And Robert, it looks like you're treating it aggressively. You're treating the anaplastic component of this.
Yeah, the American Thyroid Association guidelines for anaplastic, which were now 5 years old, the one area that there was not full agreement on was how to handle the, quote, incidental anaplastic. Most people felt that you should certainly give IMRT even if it's a focal area, but there was disagreement on whether or not to give adjuvant therapy after that. In the previous session, I did show studies from a paper that did show that IMRT followed with chemotherapy provided longer survival even in incidental anaplastic thyroid carcinoma than just surgery alone.
And so let's talk about surgery. Bob, Mark, any comments about surgery in a case like this?
I would generally agree that if one knows it's anaplastic up front, I'd be hesitant to be aggressive. I certainly wouldn't remove any important structures or violate the laryngotracheal complex. The problem you have is that if you've gone down that road, embarked on a surgical procedure that it's hard to back out because, as was pointed out, by Dr. Sadow, the surgical procedure will determine how much disease is left, and so I would generally try to avoid, if I knew ahead of time, and that generally leads me to an open biopsy to get good material. And if you have this issue with poorly differentiated and where is it on the spectrum, sometimes molecular testing to look for p53 mutations or other features might help. So in general, I wouldn't treat an anaplastic thyroid cancer aggressively surgically. I'd try to figure it out preoperatively.
Mark, anything?
I agree with everything Bob just said. I think that we sometimes do see these situations where we don't know the patient has an anaplastic component until we get the final pathology back. And I agree with the treatment in terms of radiation therapy here. I think addition of chemotherapy would be something to be considered, but in an 82-year-old, I don't think that that's something that we're really going to be offering him. In terms of the surgery, I agree with what Bob just stated. This does not sound like it was a tumor that was particularly invasive of the laryngotracheal complex. It sounds like it was 7 centimeters. There was extradural extension, but it sounds like the patient tolerated the surgery pretty well. He was able to go on to post-op radiation therapy, didn't need a trach or anything like that. So it sounds like that the right surgery was done in this case.
And Dr. Sang, any comments about radiation?
I agree with how this patient was managed, and I think in our experience, the even incidentally discovered anaplastic thyroid cancer, the aggressive component usually dictates the clinical course with an aggressive behavior, so we would offer a postoperative radiation in such patients. And now the standard is either with IMRT or VMAT, or volume modulated radiation therapy, pretty much a very similar type of approach. Thanks.
I was curious, while we're on the radiation question, that he was given radioactive iodine, and I thought that was kind of an interesting approach, and wondering, Dr. Smallridge, was that driven by the PET, the FDG non-avid nodules? Because at 6 millimeters, they may have just been non-avid because they were sort of below the limit of FDG uptake, and I'm just kind of curious, what was the reason when you were going to do local therapy and you had distant disease of anaplastic?
Well, the reason for the therapeutic dose was because we did a diagnostic scan that showed radioiodine uptake, which wouldn't have been present in anaplastic. I can't say that some of those nodules could be anaplastic, but given that he had multiple bilateral small nodules, possibly below the PET threshold, but they took up iodine on a diagnostic scan, that to me is enough to, if we didn't delay his IMRT, which we felt we couldn't by doing the common stimulated TSH, we felt we could slip it in. Normally, we would have waited months. If I have a patient with anaplastic who also has differentiated thyroid cancer, and we're going to consider radioiodine, we wait to see if the patient can live long enough to do that. But we had about a week of time when they were going to simulate him for IMRT. He had to recover from his surgery. He was radioiodine positive, so we took that as an opportunity to perhaps treat, stage 4 disease that might be treatable. Now, we won't know until a couple of months from now when we restage him what's going on in his lungs.
Marcia, Keith, any comments on the systemic therapy components of this?
Yeah, I think that this brings up a very good point. There really are different flavors of anaplastic. And in our practice, we've been seeing it. I'm very worried that we've been seeing a large number recently, like 2 or 3 a week. And there's a very big difference between the 50-year-old who presents with a large mass and no differentiated component, and the 80-year-old who presents with a differentiated component, probably has had it for years, and that's why they have metastatic disease. I totally agree with the care of this patient. I think it was kind of fortuitous that he got his radioactive iodine before. We have actually given radioactive iodine afterwards, often because the patient's still around a year later, because if the surgeons have done a great job and gotten it all out, sometimes these people end up being 3-year survivors, which for anaplastic is very good. But I think it also brings up a good point that when we're evaluating trials with anaplastic thyroid cancer, and you're looking at people who, many times they have anaplastic thyroid cancer, the initial anaplastic thyroid cancer is taken care of, but they have progressive disease based on these lung nodules. I worry when people say that they've got response rates in anaplastic thyroid cancer when probably the lung nodules that are responding are actually the differentiated
Right.
component. And this is going to be the bane of the existence of all of the anaplastic trials going forward because you can't obviously biopsy all of them. But I think it brings up a very good point of the flavors.
Yeah, that's a good insight, Marcia. Keith, last word?
Not sure I want the last word, but we are very concerned when we have even 5% anaplastic, because I can't tell you how often it is when we start treatment and we see distant metastases within a few weeks.
Yeah.
And so we tend to look at a minor component as maybe a therapeutic opportunity, but this is an 80-year-old patient. He was offered but declined cytotoxics. So I think the management is absolutely reasonable here, but we tend to at least offer an aggressive approach. And although Marcia may shudder when she hears this, we've treated patients like this with cytotoxics who are over 80.
Yeah.
And we just had one die about 10 years out from a neurologic disease, NED. But we don't know what would have happened had we not taken an aggressive approach in him either.
Yeah, yeah.
I actually agree.
And there are data to support that, irrespective of age. So wonderful case. Great way to get started. Keith, I'll invite you up to the podium. We'll talk a little bit about redifferentiation, I think, right?
Yeah, so now for something completely different, as they say. So this particular patient, I have a couple slides about the patient, but sandwiched in between some dream sequence slides also. So this was a 60-year-old woman with follicular thyroid cancer and bone and lung metastases at the time of diagnosis, and this is the chronology. So we started in 2006 with near total thyroidectomy, again, metastases from the start, and then was given radioactive iodine in December of '06, and then about 6 months later in July of '07. And if you look at the numbers, you see we're somewhat over 200 millicuries. But there were other lesions that were more threatening. These were focally palliated in bone with radiotherapy and/or surgery. And the TSH was suppressed, zoledronic acid was ongoing, there was disease progression in bone, which prompted a switch to denosumab, another anti-resorptive approach which may be more potent. And so we were faced with the question of what do we do next? This was a referral case from outside. So when we think about these cases, I tend to be a little bit odd, and I'm trying to avoid using a kinase inhibitor. I'm trying to figure out, have we done due diligence? And so there is a newer opportunity to treat these patients with redifferentiation therapy, which we'll talk about. So here's a FDG PET scan from November of '16, and the questions we had were, what do we do? Do we continue TSH suppressive dose levothyroxine, watch the progression, treat focally? Do we consider a kinase inhibitor, more radioactive iodine, or other? And this dream sequence series of slides relates to an ongoing clinical trial, which is led by Alan Ho at Memorial Sloan Kettering, with the preliminary data you'll see on the next slide, in part derived by the group of Jim Fagan. So this particular trial is meant for individuals who have at least one lesion with radioiodine uptake. And in that case, there's randomization to either get REI plus placebo or else a attempted redifferentiation with selumetinib, a MEK inhibitor. And the effect of placebo plus REI or selumetinib plus REI are evaluated in this randomized strategy to compare outcomes. Is there a difference? So the data, the rationale are listed here, and Jim has done very elegant work with mouse models to show that basically if you have MAP kinase alterations, you attenuate NIS signaling RAI uptake, and this can be restored by reversing the underlying MAP kinase defect. And the intention of this trial is to do this strategically with selumetinib. So we did so this is the data published, these are data published in New England Journal of Medicine showing an example of the redifferentiation, where on the left two panels you have a baseline iodine image and then a after salumetinib, and then you see a measurement response, resist response in a series of patients who were treated. Very encouraging preliminary data, to be sure. So in this patient, we offered this trial approach, and the diagnostic scan is presented on the upper panel with a corresponding CT showing one of the lung metastases below. And so we have just very early outcome data, and what you'll see is that the post-salumetinib scan is much more, showing many more RAI avid lesions, and then after a period of observation, we see some decrement in the size of the lung metastasis. We're still following this patient. Now, you may ask, how do I know in a randomized trial this patient got salumetinib?
I was going to ask that.
But we know because of side effects. I think we've treated 6 patients now, and it's very clear on the basis of side effects in a majority of the patients, at least who is definitely getting the drug. So I think up for discussion is this question of, can we enhance radioactive iodine therapy in patients who may have some but not optimal therapeutic activity of RAI? So Ezra, Master of Ceremonies.
Thanks, Keith. So incredibly encouraging first scan. And I was going to ask you that question in a placebo-controlled trial, so you answered it. But I'll turn to the rest of the panel. Marcia, maybe start us off. What do you think of this strategy? What's going on? And how would you approach this?
I think it's a very interesting strategy. And I guess the first thing is I have a question to throw back to you. If you have a patient who's had 7 weeks of salumetinib, you did this study with salumetinib as a single agent. Could that effect have been due to the salumetinib alone?
Yeah, so thanks for remembering that study. I'm glad somebody read the paper. So the single agent response of salumetinib in that uncontrolled single-arm phase 2 study was very low. In fact, there was only one confirmed partial response. That was perhaps not coincidentally in a patient with a BRAF mutation, but I wouldn't expect salumetinib on its own to produce a very robust response rate. So one case, uncontrolled, I'm inclined to believe that the dual action of the radioactive iodine and the MEK inhibitor had a role here.
Right, so I think we have to now see the data, and I personally don't do things before their data is published, but I think it's very promising, so we're looking forward to when these read out.
Peter, any thoughts around pathologically what tumors may be more likely to? I know that your institution has done a similar attempt in BRAF mutated patients.
Well, I was a little bit curious to know what happens in the intervening 9 years, because the data was presented from 2007, and the next slide said 2016. So I was sort of curious to know what happened between 2007 and 2016 in this patient, since there seemed to be progression, then all of a sudden we jumped 9 years. I think that we have seen some of these cases before, but the interesting thing is the way how the metastases function, because we don't typically see these types of metastases in BRAF positive tumors. Typically, we think about the BRAF positive tumors having local recurrence, local lymph node recurrence, rather than seeing kind of the lung bone mets that we see typically from RAS mutated tumors that are follicular carcinomas and not papillary carcinomas. So those are the things that I'm thinking about here, and we've had in terms of our experience, has been rather small, very limited number.
Yeah. Wonderful. Any other comments from the panel on this case? Great. Thanks, Keith. So let's change gears once again to medullary thyroid cancer, and I'll introduce Dr. Ferris to present the next case.
Thank you, Ezra. Thanks to the organizers for including me on the panel. Great to see Greg's son I'd want to be at any meeting where your son can come. That's fantastic to partner up. So this is a case of an aggressive medullary carcinoma, which we actually knew at presentation. This was a relatively young man who commuted back and forth from Western Pennsylvania for an oil company, and so that plays a role a little bit in the follow-up and so on. When he was back, got needle biopsy for a noted abnormality on his physical exam. And so my first question is for Dr. Sadal. Tell me about needle biopsies for medullary carcinoma. How reliable are those, and is this normal to have a needle biopsy in a definitive diagnosis?
Yeah, actually, that's one of the easy ones in terms of medullary carcinoma. There's a fairly specific look to these cells. Typically, we call them comatoid or plasmacytoid, the cells. So they're usually quite easily distinguished from any thyroid follicular cells. So it's not, sometimes there are a couple of pitfalls involved, but it's a pretty straightforward diagnosis by FNA.
So this patient was essentially asymptomatic. There was nothing in the history or anything to suggest syndromic, and so his only relevant feature with regard to surgery is that he had had a gastric stapling procedure, and so what does that mean to any of the surgeons?
So you're certainly going to be more concerned about any hypoparathyroidism in this patient because the patient may not be able to absorb calcium as well due to the gastric procedure. Certainly you would want to do upfront genetic testing on this patient to see if they were an MEN patient, but I think that certainly makes you cautious, to be much more cautious with those parathyroid glands when you have that gastric bypass history.
So he came in with a neck and a chest CT because of this outside diagnosis. Would this be the first radiographic test, or how would you feel about ultrasound versus CT in a patient like this?
I would get both. I mean, I would get both an ultrasound and a CT a neck on somebody who, probably CT neck and chest, as was suggested here, on somebody who had medullary. So I wouldn't differentiate between the two in terms of, I would get both studies.
Okay, any other comments from the panel? I want to pick on Mark.
Well, I'm going to pick on Mark. So why do you get both, Mark? Expand on that a little bit. What do they add to each other?
Well, so medullary thyroid cancer is one of the more aggressive thyroid cancers that we see. I mean, certainly different medullary thyroid cancers behave differently, but I think certainly the mainstay of any thyroid cancer imaging is ultrasound. You're always going to get an ultrasound. So the question really here is whether you add a CT neck and chest to that study. The addition of the CT chest is not very much. It just requires going further down on the neck CT. Usually when you're getting a neck CT, you're imaging the upper mediastinum anyway. So I don't think it's a bad idea to go lower and get the full CT chest on the patient. So then we're back to the question, does this patient need a CT neck? And so we routinely image CT necks for all of our medullary cancer patients. I think there are instances when CT scanning can add to the ultrasound. Certainly cases with larger and posterior tumors where you want to see what the tumor is doing in terms of the tracheoesophageal groove, the trachea. And then in terms of lymph node metastasis, there are cases where lymph node metastasis can be easier seen on CT than on ultrasound. Certainly superior mediastinal lymph nodes, retropharyngeal lymph nodes, and lymph nodes deeper in the paratracheal bed.
So I just want to reinforce both of those points that Mark made because I think they're very important. I completely agree that I think there are certain nodes that will show up more on ultrasound with a good ultrasonographer, an experienced person, versus CT. It's not totally clear to me why that is, even in a lateral neck, but I would get both as well, particularly in a medullary case because outcome is so determined by upfront surgical therapy. It's really a surgical disease that you absolutely want to know where every node is. The second, as I alluded to, this is a pretty heavy-set guy, and the mediastinum is really not well imaged, and so you really have to make sure that your central compartment cleanout is ideal. So I think that's the other reason ultrasound is not great.
Bob, I want to stop for a second and maybe talk a little bit about genetic testing in medullary thyroid cancer and see what the panelists think about getting genetic testing on this individual, and what would you get? Keith, Bob?
My feeling is everyone needs genetic testing, period. And I don't care if they're 50 or 60 or 70. I've seen RET positive, and that has implications not only, if they are RET positive and they're 65 and they've gotten along that well, they're probably going to do well after treatment. But for the family, it's very important to know. So, and the surgeons are going to want to know also. What I was wondering was if we knew that the RET testing was negative and you did further imaging, you knew your calcitonin and it was 1,000, 1,200, so you went ahead and did some more preoperative imaging and you found some lesions in the lung, so now he's not just local disease. Would this affect what the surgeon would do, particularly given the concern about creating hypoparathyroidism? So, if you had only a lesion on the affected lobe, but you had metastatic disease, would you do less than a total thyroidectomy to perhaps preserve the parathyroids on the other side?
I don't think it would change my surgical management. I would still do a total thyroidectomy and bilateral central compartment dissection. I think it's just something that the surgeon has to keep in mind in terms of care with the parathyroid glands. But I don't think it would particularly change my management in terms of what I would recommend surgically here.
So, at the risk of staying on slide 1 for a prolonged period, please.
So
Dr. Bible.
the calcitonin was discussed earlier.
That's what I'm trying
It's important, but there's one more wrinkle which maybe we can talk about with image, and that's the newly enhanced gallium dotatate PET imaging in medullary. We've started to use this because it's sometimes affected decision-making, particularly with radiation therapy. We found that this has upstaged some patients, so we've declined to do radiation therapy because we figured it would be less effective in controlling the disease durably. And so maybe we can use this discussion to breach that at some point.
I think, in fact, we might have an opportunity. Let me just kind of show this image. You can see in the left thyroid lobe, it's not ideally imaged there, but behind the clavicle is the primary mass on the left side. Maybe a little bit better image there where we looked for a metastatic adenopathy, and it's maybe hard to read, but there was some in a 2.8 centimeter nodule, and no adenopathy in the lateral neck, but a couple nodes in the left paratracheal region. So here he was. This is at baseline. So we had a CT scan. We have this calcitonin. Dr. Bible, what does 1,600 mean to you? And what does that mean for your imaging?
Well,
the ATA guidelines pick 400.
Yeah, so there are a couple things we might talk about. So my first trite comment is it's just a number. And then I have another comment, maybe Ezra can comment, or Marcia, and that is, as a medical oncologist, I like it when the calcitonin to CEA ratio is great, because I interpret that as more likely a better differentiated tumor that's it's more synthetically active, what it's supposed to be making. So I would comment on that. But I think it does raise this question of if there might be an influence on surgery for additional imaging, this would be a time to consider it, but otherwise I'd probably wait and see what happened to the calcitonin and CEA.
Post-op, you mean?
Yeah.
Uh-huh.
I don't really have anything to add to that. I totally agree. I wouldn't necessarily trigger me to do a lot. I would probably wait till after.
Okay, so we went ahead and imaged for liver mets and the lung, which had already been imaged. That was all negative. We did get an ultrasound, and so this describes that. Suspected extracapsular extension, and in this case, where the CT suggested the lateral neck was clear, ultrasound indicated likely level 2 and 3 lymph nodes. Any other imaging? This was a few years ago. We did not get a gallium scan.
I missed out. The liver was imaged with MR.
A triple phase CT.
Triple phase CT.
Yeah. Later, we got an MR, but at this pre-op
Yeah,
setting.
so this is always, time marches on. With the neuroendocrine tumors, we can miss disease in the liver very easily. So I'm a real proponent for MR in that context.
And actually, comment, Keith, on what specific MR study you'd get, because there's some subtlety there too, right? Do you want to comment on what specific order you would put in?
So fortunately, our radiologists at Mayo don't care what I put in because they'll do what they want. Whatever they want. But I tend to rely most heavily on T2 weighted images and then GAD enhanced T1. So those are my workhorses, Ezra and others.
Yeah, so we specifically do an EOVIST study in the MRI that tends to show neuroendocrine cancers a little bit better. Unfortunately, we don't have a radiologist on the panel, but that's what I've been told to order.
You guys are doing pretty well, I have to tell you. Okay, so we went to surgery, and I know you can't read this, so I'll read it for you. About a 2.5 centimeter primary tumor with extrathyroidal extension, a positive margin at the tracheal wall, and intraoperatively, this was encasing the recurrent nerve despite its pre-op functioning. There were 3 of 10 positive lymph nodes in the paratracheal area with extranodal extension, and in the lateral neck, 62 nodes were removed with 10 positive and extranodal extension seen there. So the decision was made, actually scrubbing out and talking to his family, to sacrifice the nerve, and he had an immediate medialization procedure. And now we have a patient whose calcitonin went from 1649 down to 89. And this is when we started more aggressively scanning. He got an MRI of the spine as well as the liver, finding no sites of disease, just an isolated calcitonin.
So, Bob, I want to ask Richard, any role for radiation given the pathologic findings in this case?
It is a consideration, but before we make that decision, we need to distinguish whether there is likely residual disease in the neck versus in other organs, and radiotherapy won't help tremendously if there's systemic metastatic disease. So we like to say that we would confine the radiation treatment offer to patients who likely has residual disease in the neck without distant metastatic disease, and also that the local regional disease in the neck cannot be further treated with surgery. So those are the requirements. So yes, we routinely would do a PET scan in these patients and have a surgical re-review depending on what takes up in the neck, whether further surgery is indicated before we come back to. Like obviously if it's nodes, then maybe further surgery is required, but if it's either negative or non-specific with low thyroid bed uptake that's more diffuse, can't be located, then surgeons don't want to go back to re-explore, then we would consider the adjuvant radiotherapy option.
So others want to comment on PET-CT. Our radiologists are not particularly fond of that for medullary. Is that something routinely done?
I'll jump in and comment. You don't mention ultrasound neck. So that would be, I think, an important complement, because with CA, I'm going to pitch this anyway, with the CA relatively low and a lot of neck disease with a tremendous initial drop in calcitonin, you have to, as you indicated, consider first that this is a persistent disease in the neck. We see a lot of patients referred in for tiny elevations in calcitonin, and then the endocrinologists are hyperventilating about, oh my goodness, they must have persistent disease, what's going on, what should we do, should we start a kinase inhibitor? And so the thing that's most concerning is probably the doubling time, but I'm suspecting the disease is probably still nodal until proven otherwise, and I probably wouldn't do MR head. I would do MR if I were going to check the brain, the CNS.
So we did image, couldn't find anything radiographically, including ultrasound. in the head and neck.
And you may be about to breach the gallium dotatate scan question, I don't know.
Yeah. This was a few years ago.
Yes. A lot of this has just come online within the last year, and I don't know that it's widely available. So Ezra, you probably have availability, and Marcia, you don't. So it tells you that, you know, it's a very select series of centers that have implemented it at this point, but it is sometimes maybe too sensitive, and one has to caution patients if you go that direction, that you maybe see things that you had, you know, you'd never have seen before, but to the effect this might allow you to monitor the anatomical disease progression, it can be very helpful. But again, it's the dark underbelly is too sensitive in some patients.
So you
I think
mentioned, oh, go
one
ahead.
important thing I wanted to add in this case is that with this patient who doesn't have any anatomic indication of disease radiographically, I mean, it seems like another very reasonable option instead of thinking about all the different various imaging studies you could get is just to continue to follow the patient, because ultimately you're not going to treat this patient any differently right now anyway. You're going to wait for this patient to manifest with disease somewhere, and then when they do, then you follow that disease anatomically and start to treat them as needed.
So I'll go quickly through this. Actually had a bone met in the leg, which was resected, and then just most recently came in June and has a paratracheal, now contralateral, on the right paratracheal, and you can, I think, see that here, right in the groove. And so now he's presented, his calcitonin is now over 5,000, and he does have disease in the neck. He's got a stable airway, and the question is now really, as was brought up, is there a tyrosine kinase option given that he has an immobile left vocal fold?
Richard, would you radiate this guy? Disease in the neck?
This patient had metastatic disease, although oligometastasis, just 1 or 2. So if neck control is a significant concern, radiotherapy would certainly be one option. But again, we'll conference these patients and get a surgical opinion about whether the repeat surgery is possible or wise. And if not, then it's a reasonable maneuver to exercise radiotherapy at this time for disease control of the neck. Yeah,
Keith,
provided
Marcia,
the patient accepts it.
TKIs? Any role for TKIs here?
I just like to preserve their TKI-free life as long as possible. And so if I was able to do radiation, maybe even a palliative course as opposed to a big block thing, a couple of weeks to get that one controlled, I probably would do it. But I'd also point out that lots of times our patients who have this super high calcitonin level, I think most of the time they're harboring it in the bone. And I think that's why we sometimes have trouble seeing it until it's actually big enough to cause a lytic lesion, and now you can actually identify it. So with him, I'm just worrying a little bit more about the bones and probably would put a little bit of attention on, I'd warn them, if you have any bone pain anywhere, let us know. But I would probably do a little bit of radiation and continue surveillance until I had something I was treating that wasn't local.
And you've had one bone met already.
Yep.
So the other questions would be, do you start antiresorptive therapy? Mm-hmm. And the thing that gallium dotatate, or it's a glorified version of an octreotide scan. Mm-hmm. So the other thing that I sometimes think about, probably not relevant, is could this, sometimes patients, maybe 15% will have response to octreotide, and there's going to be a radiotherapeutic reagent which is now used in the UK, but we think it will come online in the next year, that may be available, that will be dependent upon octreotide, sandostatin avidity. So this may be an area to consider at some point also.
So he was recommended to have 30 gray palliative radiation, which he just completed in July. Thank you.
Thanks, Bob. Thanks, Bob. That was terrific. I did want to take a little bit more time on that one because it's our only medullary thyroid cancer case. And so with that, Richard, do you want to come up and present yours? Thanks.
Thank you, Astra. So I'm going to recycle back to the initial theme of an anaplastic thyroid cancer case. But first of all, maybe I'll just take a quick survey among the audience. In your center, when among all the anaplastic thyroid cancer patients that you've seen over the years, what's the proportion of patients that you've had that were resected or were resectable and at gross disease removal? 80% or more? 50%?
Ask for a show of hands.
40% show of hands? 20%? Under 10%? So it seems at my center it's probably about 10%. So keep that in mind when I run through this case. Okay, so a 68-year-old man with nodular thyroid disease for a number of years with really few comorbidities. I have a left-sided thyroid nodule that increased to 3 centimeters. And the first FNA done showed poorly differentiated cells, some large spindle cells consistent with and suggest anaplastic thyroid cancer. There was a second FNA done, which actually showed papillary carcinoma. Clinically, there was no rapid growth, and the patient's voice was normal with no other symptoms and no lymphadenopathy. This is the CT scan. So you see that abnormality in the left thyroid lobe, both on the axial and the coronal cut with some central hypodensity suggesting some element of necrosis. A PET scan was done and it showed the localized uptake with that SUV max of 14.3, and there were no other abnormality elsewhere. So the treatment plan when this patient was conferenced was because it was localized, because there were components of both anaplastic thyroid cells and differentiated thyroid cancer, was a resection followed by postoperative radiation therapy. So the patient underwent thyroidectomy and a central neck dissection. The tumor size was 4.7 centimeters. And within this tumor, the anaplastic component accounted for 70%, and the differentiated component 30%. There was angioinvasion, there was focal extrathyroidal extension, microscopic margins are positive, but the gross disease was resected. So it was an R1 resection. Central neck, some lymph nodes are positive, and there was a combination of some nodes with differentiated thyroid cancer, but 3 definitely had anaplastic thyroid cancer. Pathologically strong P53 staining, loss of TTF, and thyroglobulin. So it's a T4B, N1A, stage 4B type of R1 resected anaplastic thyroid cancer. So on the left is the pre-op scan on the coronal, and on the right you see that there's no gross residual abnormalities shown.
Can I stop you already, or?
Yes.
Because I think we've gone too far. One of the things that's really important, we talked about too, we mentioned first of all, are there difficulties in diagnosing by FNA medullary carcinoma? So I want to go back here to this FNA, which had kind of mixed features that you see there. And I think one of the things that we've been de-emphasizing a couple of things that really need to be re-emphasized. And first of all, serologies, because I think we haven't been talking about it very much. But when you get an FNA like that, the first thing you better do is do a serum calcitonin. Because I've had a number of experiences now, not one, so since this is more than one, I'll say that you want to first of all exclude that it's a medullary carcinoma, because there are some features that can look like anaplastic that could be a medullary, and a calcitonin would be really, really helpful. Of course, we jumped the gun, so you gave a diagnosis already, but in the up front, before you do the surgery, in terms of surgical planning, you better do a serum calcitonin. The other thing, too, when it came out, we talk about a percentage of differentiated carcinoma and de-differentiated carcinoma. We need to know what that differentiated carcinoma is, because there's definitely the majority of cases of anaplastic carcinoma, for the most part, arise and associated with follicular thyroid cancers, not papillary carcinomas. But it is important to know that in terms of any type of adjuvant therapy that may be given or may be useful for the patient. So I didn't mean to interrupt, but I feel like we kind of keep jumping past the
Excellent
you know, the
point.
preoperative workup.
Yeah, excellent point. A calcitonin was done, and the purpose of time, I just skipped by some of those features. It
skipping.
was negative. Yes. So this case, there was a preoperative diagnosis of anaplastic thyroid cancer, and but the features are such that it was deemed resectable, and maybe I'll have Bob. Is that what you would have recommended as well in this situation?
Would you resect
I'm sorry, what was the question?
I think he's asking.
He's asking about surgery. Would you recommend? I mean, anybody can answer.
It's actually very similar to your case that that you presented.
Yes.
Or Mark.
I think that looks like a surgically resectable case, and I think surgery and postoperative radiation therapy and consideration for postoperative chemoradiation therapy is a very reasonable option for that patient.
Okay, right. So those are the two options, and the patient was treated with a hyperfractionated accelerated protocol that we have used at our hospital, and the biologic effect is very similar to a fractionated course, but we have some data showing that this regimen has a slightly better result in terms of local regional control, so we went with this, and this is our own data that shows this. I suppose similar patients, the other option would have been to use chemoradiation therapy as well, which is also a very good approach, but there's a bit more toxicity with combined treatment.
Could I ask you a question about the dose of radiotherapy? The earlier literatures back in the 1990s and early 2000s differentiate between palliative and higher dose in the 4,000 plus range.
Yes.
The more recent literature is using IMRT and is up in the 6,000 to 6,600 centigrade range. Is there do you know if there's any real difference between 4,000 and 6,000 other than the way it's delivered, or toxicity, or outcomes?
The ability to give a higher dose more safely is since the IMRT era. So we've given higher doses, although the data comparing a 66 gray, for example, with a 40 or 45 gray is sort of marginal. And other than what data we presented there, with a cutoff of 40, but there is, once you break down dose groups, there's not, really clear data to indicate a dose response from 40 to 66 gray. But toxicity-wise, we like to say that it is very similar. So we've given higher dose therapy now with the same degree of morbidity, certainly from the acute toxicity standpoint. So that's what sort of everyone is adopted. Question from...
So I may be going rogue here, but if you have an unresected anaplastic thyroid cancer, do you do adaptive planning to be responsive to the regression of tumor? How do you approach that in anaplastic, where you sometimes can see regression in the course of treatment?
Yes, we do. Different departments would have different thresholds about when do you adapt. That is, after a tumor shrinking after 2 or 3 weeks, you can go back and replan the case, accounting for shrinkage to try and get tighter on the gross disease and spare more normal tissues. In general, yes, for rapidly growing tumors, sometimes you see rapid response, and then you can adapt once or twice throughout the course, but generally after a period of about 2 to 3 weeks you can assess. In my department, we do monitoring. We'll do basically a cone beam CT on a treatment unit every day. They look for change, and once it reaches thresholds of shrinkage, we will adapt. So this patient goes on with treatment, and that just meant to show the modern way of assessing and treating with IMRT. All the normal organs and tissues are checked very closely. And 1 month following external beam radiotherapy, on a routine CT scan, there are lung nodules. And this goes back to Bob's case, which already had been discussed about question of whether this could be differentiated thyroid cancer or anaplastic thyroid cancer. So at that time, we did a scan, we did a total body scan, and the patient did not have iodine-avid disease. So radioactive iodine treatment was not given in this case. And he was referred to our medical oncology colleagues who started the patient on chemotherapy with Taxol. But there was no favorable response with that. So in this situation, I referred the patient to our phase 1 group and looking for phase 1 drugs, and this is several years ago, and patient got tested with BRAF, and he was positive and had a trial of sorafenib. So maybe a question for Marcy: what should we be looking down the pipe about anaplastic thyroid cancer, about promising agents, other than what's been tried in this patient a few years ago?
I'm not sure that still isn't differentiated, just non-avid.
It is not avid.
Yes, but
So-
I'm saying it still may be a differentiated component and not
Good
anaplastic.
point, yes.
So I still think kinase inhibitors would be appropriate in this case. I mean, as long as what's in the neck is controlled and there's nothing else going on.
That's correct.
I could almost tell with serial scans whether that's the differentiated or anaplastic, because usually the differentiated will grow very little. You could even do a surveillance scan in 2 months and determine what's going on.
So Marcia, in the face of a BRAF mutation, and let's say you have all the drugs that are in existence, would you treat this patient with a BRAF inhibitor or with a VEGFR TKI?
So we had this discussion in our other session. So I don't tend to go to the BRAF inhibitors first line. I have 2 FDA-approved drugs. I tend to use them first. And I would, but I would use it. I mean, for differentiated, you have 3 drugs. You have sorafenib, lenvatinib, and the BRAF inhibitor. So I would definitely get it in there. But the other thing I would say with this case is that really, if it's really controlled in the neck, that's a very small lesion, and it may be that guy, as long as his neck is controlled, he might actually go for several months before actually needing treatment. So we probably would use a kinase inhibitor, provided if it grew a little bit quicker than that, we're trying second line chemotherapy, and assuming it's anaplastic.
Okay.
So Keith, you want to say something?
I do, and Ezra, you may say the same thing, and I'm afraid that Marcia and I have a similar view, so I may have to show my hand. So
You mean you have the same view?
we often have the same view.
Oh, that's nice.
Put you on
So-
the table together anymore.
Right, well, maybe not. So the issue with BRAF and anaplastic is one that's emerging quickly. So at ASCO, there were data presented which looked at the same combination that's used in melanoma, which is a MEK inhibitor plus a BRAF inhibitor, dabrafenib plus trametinib, and maybe you'll go that direction. So the indicated survival and response in anaplastic was stunningly high, such that it might perhaps superimpose upon the differentiated survival curves. And so Marcia and I are, always wanting to have clarity on the issue of what component might have been differentiated in the assessment of response, but the survival outcomes speak for themselves. So I think we have to watch this space closely in terms of this novel combination, because this is something that is, very exciting in terms of the preliminary data, but we really need to have more validation.
Can I just add one more other point? I did talk to the people who ran that study, and they said that they had an extraordinarily high number of people who had differentiated thyroid cancer in their biopsies. So
Do you go
it
back
almost-
re-biopsy? Do you biopsy some lesions that are biopsyable in order to guide your therapy?
So we do this pretty commonly in circumstances where the nodal disease is both differentiated and anaplastic, because even in your initial pathology, you had one node, I think, that was differentiated and several that were anaplastic. So I see patients who come up with oligometastatic recurrences in both the disease, both of their separate cancers. So we rebiopsy frequently.
Okay, so just 10 seconds, I'll wrap up. This patient ended up with very rapid widespread metastasis to the adrenal glands and the lung disease. And he actually died exactly a year from the initial thyroidectomy. It just shows that the behavior is much like anaplastic thyroid cancer. So thank you. I think we'll move on to the next case.
Thanks, Richard. We'll move right along and introduce Marcia Brose, who's going to give us the next case. Thanks, Marcia.
So in the interest of time, I'm going to actually go through this a little quickly, especially because it's not about the early stages of disease, and I apologize to our colleagues here who might get bored because I'm skipping over it way too fast. I want to talk about a 55-year-old male who went through a thyroidectomy and was diagnosed with poorly differentiated in 2008. And it was a fairly large poorly differentiated at the time, had positive margins, invasion into the skeletal muscles, paralysis, right vocal cord paralysis. And he actually, because it was not felt to be a complete resection, underwent external beam radiation to the neck. And within a couple of months, he also was given radioactive iodine, but there was absolutely no uptake, which I don't think would be a surprise to many people here. But within a year, his thyroglobulin was already increasing again. And I will point out that it was fairly quickly determined through a PET CT that the recurrence was happening in an area posterior, in the posterior neck, and in a place that was not easy to be resected. And he never had any metastatic disease elsewhere. So this is a man who really could not be fully resected, and in spite of radiation therapy to the neck, recurred in the neck and in the bed where obviously more radiation was not possible. And surgery wasn't really going to be possible without actually giving him a trach. And even if you did, you're never going to get it, the whole thing again. So he was actually, this is prior to when we really had, he wouldn't have been eligible for the trial, I believe, at the time. He didn't have metastatic disease, and he was hard to actually measure. So he was followed, but unfortunately he continued to he continued to grow. And they did try one more round of radioactive iodine. I'm not even sure totally why, but there are a couple of areas that might be a little bit positive, but again, near the esophagus, I believe it started up in the TE groove, but then continued to grow. And so they tried to actually, not actually do additional therapy. It was known that it was going to progress, and in the interest of this young man trying to, maintain his voice for as long as possible when it wasn't going to do anything. But eventually, he, by November of 2011, did require a trach. And unfortunately, his disease just kept growing in the neck. And he did have next generation sequencing, and unfortunately there were no BRAF mutations or something that would have helped us with other therapeutic options. But of course, we still had we had chemotherapy that was available. So he was started he wasn't actually on the trial, but he was started with full dose sorafenib, and very consistent with the data from the Decision trial with a poorly differentiated tumor, he actually progressed in 7 months. And that seems to be the average for the poorly differentiated. It's around 5 or 7 months. So whenever I have a poorly differentiated, even though I know they'll get a benefit, I'm already planning what am I going to do next. We had a trial at the time for adding in everolimus at the time of progression, and we did that with this patient, and interestingly, he tolerated it fairly well for quite a while, had problems actually with a sinus infection that kept dropping his white count, and he became neutropenic, and we couldn't understand why, because sorafenib doesn't usually cause neutropenic, and finally we determined that he already had a low white count to start with, and he had this chronic sinus infection. Every time it flared up, his white count must have all gone to his head. Because he actually got kicked off the trial because we couldn't keep him from being neutropenic, and I was going to get deviations like crazy. So we did take him off of the trial, but ended up going back and treating him anyway off the trial because he was doing well. And so he actually did for 3 years and a month. So he had a disease right now, bilateral neck, filling the neck, stabilized it for a full 3 years before it grew again. Which I think is amazing considering he only got 7 months with sorafenib alone. But then he started to progress, and when he started to progress, it actually became really nasty. He grew kind of like nodules on top of what was already a neck full of disease. And I show you this scan as an example. So you'll see that his trach is, I mean, he had a trach prior to when he came to us. You'll see total obliteration of the upper airway. And also, you can see the nodule there in the right anterior neck growing, and it actually involved the skin. It grew right out through the skin. By the time, so he had been able to swallow and everything, even in spite of the large mass, and I'd say the part that's not the nodule had been mostly stable. He was able to swallow until about a week or two when he started to have trouble with dysphagia, and at this point was only able to take in liquid. And so at this time we started him on lenvatinib. I'll just point out this is the skin involvement, so you can see it's growing right through the skin. And now we had a concern because we're aware that there's a concern about wound healing, especially with these VEGF receptor inhibitors. But we had him see the surgeon, he saw everybody, and we felt like there was absolutely no choice.
Marcia, can I interrupt for a sec?
Yeah.
Did you ever consider radiation? And
He had already been irradiated.
Oh, he had already
in
been
that
irradiated?
area.
I missed that.
Yeah, so he got
okay.
irradiated very, very early on. So that was the first thing that had happened. Yeah, because he had positive disease in the neck after the surgery. He was irradiated initially, right. So radiation wasn't a possibility. We did send him to our surgeons who I thought maybe could do something for the wound. Nothing, because this was considered completely his tumor. And so we went ahead, warned him about all the risks of what could happen. He could bleed out, but this guy now couldn't swallow, wasn't looking forward to a PEG tube and various other things. So we went ahead and treated him with lenvatinib. And I'll just show you, this was his neck 6 months later, with complete healing, actually, of his neck, which was a wonderful surprise for us. And this is actually his scan. So only 6 months later, he really had wonderful resolution. And in fact, his scan never looked this good. Even when he had started on sorafenib, I'd argue that the major mass on the left, maybe had been gotten a little bit smaller, but it sort of stabilized on the sorafenib and the sorafenib everolimus. That's why he was able to live for 3 years. But now this resolution is really quite remarkable, and he went in a week from a liquid diet to eating his favorite food, which is apparently pizza. But I think you can see laterally why it was that he was now pizza, able. And so anyway, this is a patient I just wanted to bring up because, one, we always avoid it for wound healing. Oh no, wound healing, and here's a guy who healed a wound on it, and also shows the dramatic responses that we can get with this new agent. So that's sort of my summary points, but in time I won't go through them.
Well, let's spend a couple of minutes, Marcia, on this because really interesting case. So in retrospect, let me challenge you a little bit. And if you had both available, lenvatinib and sorafenib, in retrospect, would you have changed the sequence of your therapy? I know it's an unfair question, but go ahead.
The answer is clearly yes. So that's why I was pointing out that this actually looked better than it ever had before I started. But I think it really brings up the point that now you have agents that can cause shrinkage. When you have these aggressive types, there might be you might want to be doing it a little earlier than you might otherwise do it. We had started with sorafenib obviously because we didn't have the other one available, but
Right.
I think that this really would suggest that would be a good idea.
Robert, Keith, do you want to make any comments on systemic therapy in this case?
I just had a question. When this thing regrew after several years, did you consider doing another biopsy to see if it had changed?
Yeah, we actually did, and I went through the slide too fast. It was exactly consistent with the poorly differentiated from his primary, almost identical.
It's not just the histologic, though, that in 5 years the panels for the molecular testing have advanced substantially. So
Yeah.
did you do
So I apologize. The CPD testing, we got it at the time of the recurrence. So when he went to see Ara to see if there was anything he could do to help, I asked him to take a little piece, and we sent that.
So speaking to that question, Ezra, of to use sorafenib or lenvatinib, the resist-response rate to sorafenib is less than 15%, but it's over 50% for lenvatinib. So if you have disease you need to cytoreduce, you have to pick your agents that are more likely to accomplish that, and lenvatinib would be in the category.
Yeah, and I'd add that the biggest obstacle to wound healing is the cancer, and so
Yeah.
you get a response in the cancer, and all of a sudden things begin to heal. Really nice demonstration. And so our last case of the session, Mark, I'll turn the podium over to you, and a little bit of a different spin, I think, on anaplastic. Thanks.
Thank Thank you so much, Ezra and Greg, and it's such an honor to be here with such esteemed panelists.
Mark, is that you in the picture?
Wow.
Get your
No,
haircut.
that is not me.
Okay.
Modern times.
So this is a final case of anaplastic thyroid cancer. I think it will bring up a couple of topics that have been discussed by Keith and others during this case, but it was a very interesting case that I share with our endocrinologist here at MD Anderson, Dr. Maria Cabanillas. And there's a big question mark, renewed hope for anaplastic thyroid cancer, because I think although we have seen some success in the treatment in all of our major centers across the country and world in anaplastic thyroid cancer, I think we still have to be cautious, and we understand that it is still a disease with a very poor prognosis. I am the institutional PI for a multi-center clinical trial by GenePro Diagnostics for molecular genetic testing of thyroid indeterminate nodules, but that obviously has no bearing on an anaplastic case presentation. So this is quickly a 60-year-old gentleman. This is, you can see his picture there. He's otherwise healthy. He has a 1-month history of a rapidly growing neck mass. He's having some mild dysphagia. He's breathing well at rest, but he tells you that at night over the last few days he's been having significant difficulty. He's having to sleep in a chair. You walk into the room and he's breathing comfortably, but you ask him to take a deep breath and he has some mildly audible stridor. You do a flexible fiber optic laryngoscopy and he's got some significant supraglottic laryngeal edema, and you can't really even visualize the glottis to see if his vocal cords are mobile. So this is certainly a patient that we need a fast workup and evaluation. So we start with a CT scan, and this is the pointer here, yeah. This shows. I'll use the pointer for our panelists here. Does it show up here actually? So this shows a very large tumor here. It's here. It's actually causing some tracheal and laryngotracheal deviation here. This is actually the hyoid, so it's extending very high in the neck. You can see that it's very significantly narrowing the supraglottic airway, and really the PET scan says it all. So this is a very local, regionally aggressive anaplastic thyroid cancer extending from the skull base to the superior mediastinum. So unfortunately, he has no distant metastasis. On that same PET scan. So we do a core needle biopsy. It's an anaplastic thyroid cancer. It does have some, in the lymph nodes, there is some mixed ATC and PTC component. And we do immunohistochemistry, and there's a BRAF and a P53 mutation. So I have, as a surgeon, my initial discussion with the patient is obviously the airway. I'm concerned that he's going to get into trouble within the next couple of days, and have that discussion with him. But he says, Doc, I'm from Tennessee. I came all the way down here. I want to see what you're doing in terms of your clinical trials. I'm not going to have a tracheotomy. I can do that back home in Tennessee. So as from our medical oncology and endocrinology colleagues, the patient declines a tracheotomy. What are our options in terms of systemic therapies, targeted therapies, immunotherapies for this patient with these mutations?
So we talked a little bit about this in a prior case. If you look at the response to kinase inhibitors in differentiated thyroid cancer, we have some data, but in anaplastic thyroid cancer, it's been very discouraging. And so the emerging question has been, can you get a extraordinary response by targeting the V600E mutation? And we might talk about, it's really the V600E mutation that is particular. If it's a different BRAF mutation, it's less likely to be responsive, and we should talk about that because there are others. And so we can see extraordinary responses even to single agent dabrafenib. They tend to be short-lived, but I think a lot of us would be thinking towards targeting the BRAF mutation here.
Excellent points, Keith. And yeah, this is a BRAF V600E mutation, as you suggested. In the interest of time, I'm going to move on this case. So the patient was given targeted BRAF and MEK inhibition, dabrafenib, trametinib for 4 weeks. You can see quite a remarkable response just looking at this coronal CT. Obviously, there's still a tumor there on the left. It's abutting the carotid artery. The patient did interestingly develop a lymph node metastasis in the left lateral neck that started to grow about 4 weeks into treatment and developed a new NRAS mutation that was actually biopsied. And you can see on the CT scan Here you can see where that lymph node looks like it's involving a little bit of the skin and the dermis. So our pathologist, Peter, have you seen this? Have you seen patients who develop, would you talk about that in terms of developing a new mutation, or actually our medical oncologists and endocrinologists can speak for it as well, in the setting of targeted therapy with BRAF and MEK inhibition?
Well, the reality is the situation is that sometimes some of these tumors are a little bit polyclonal if you have more than one area of the tumor. And as you mentioned, there's a papillary thyroid carcinoma component, which would have a BRAF V600E mutation, and then there was an anaplastic component that had P53 mutation. And the question is that both of them were seen by immunohistochemistry. P53 has increased expression and obviously in anaplastic carcinomas, but also in high-grade papillary thyroid carcinomas. The question is, what is the overall makeup of this tumor? So if you did molecular testing on different components of the tumor, would you have actually seen the NRAS mutation present there? I mean, the likelihood is that, at least in this part, there's two different components of the tumor rather than a treatment-related additional mutation taking place.
And,
Okay,
and you could argue that you've now just clonally selected for the more resistant clone. But the other thing I want to point out is, I know we're all excited about the BRAF inhibitors, but I've had exactly the same response, both with sorafenib and lenvatinib. And what's typical is they respond beautifully and they bounce back within 4 weeks. So I could get that same. So even
Absolutely.
without targeting BRAF, I think the kinase inhibitors, this is a profile that I would have seen.
Yeah, Marsha, I'm glad you said that, because the data would suggest, granted not in an anaplastic study, but that patients with BRAF mutations or RAS mutations respond equally well to lenvatinib and for that matter, sorafenib. So the presence of that mutation shouldn't dissuade you from using the VEGF receptor inhibitors. The other comment I'd make, and I'm curious about, Mark, is did you get circulating DNA on this patient? And I wonder if that would have shown both the BRAF and the RAS mutation at the beginning. Because I agree with you, Peter. I think this isn't necessarily treatment related. I think this is just the emergence of a clone that was already there.
Yeah, I think those are excellent points. No, we did not get circulating tumor DNA on this patient. So, I mean, I think it's an excellent point. This very well could be.
It wouldn't have changed your management.
It wouldn't have changed the management. Yeah. So I'm going to move on. So pembrolizumab was added at week 5 for an additional 8 weeks. The patient was given pembro. So this is now 13 weeks into treatment. The patient has now a fairly smaller, relatively, thyroid tumor. It actually still is abutting the carotid 180, and it's probably going to be involving that jugular vein there. You can see much higher. The airway looks great. This is the new PET imaging, which is quite a remarkable response. So this is now 13, 14 weeks after. And I want to specifically ask our surgeon, Bob Ferris, is this a patient who you can now take to the operating room and do surgery for?
So if I'm worried about the carotid, I think I'd want to get an MRI. The CT was certainly suggestive enough that you may end up leaving residual disease, so I'd want to have a sense of that interface a little bit better. You can clearly debulk some of this. The question is that in the end going to alter the natural course of the patient's disease?
Absolutely. Yeah, those are excellent points. So we did end up taking this patient. We have 2 minutes left, so I'm gonna keep moving on. But those are excellent points, Dr. Ferris. We did end up taking this patient to surgery. Did a total thyroidectomy in central and bilateral lateral neck dissection. The margins were close but negative, although there's no question that this patient is an R1 resection. There's no question this patient has microscopic disease in the neck. The patient did interestingly have a postoperative wound infection 9 days out that required taking them back to the OR and opening that up and draining it a little bit. And that's something that you very rarely see with typical thyroid and central and bilateral neck surgery. So it is something that potentially could be related to all of the treatment. The patient did get an additional dose of pembro 3 to 4 days after the surgery. And the surgical pathology is a multifocal residual ATC, a 6 centimeter dominant. And as expected, 15 anaplastic left lymph nodes, but then the lymph nodes in the right neck were actually PTC. And so now the question is what to do next. Dr. Zhang, any argument about this patient in terms of what they need next?
I think I would recommend radiation. It's good to have such good momentum of response with systemic agents, and then now surgical resection. So I would follow up with a reasonably high dose level of radiation therapy for local regional control.
The one question I have about for our endocrinology colleagues, and this will be the last question, is endocrinology and medical oncology colleagues, is when you give that radiation therapy, obviously you're also concerned about the targeted therapy has had such a nice effect, and you have the patient on immunotherapy as well. What are the concerns, particularly with giving radiation therapy, either concurrently when you've given dabrafenib, trametinib, have the patient on Pembro, or after that they've received those medications? Keith, Marcia, Bob, any comments? Ezra?
None. There doesn't seem to. If you're talking about toxicity, I wouldn't worry about it. If you're talking about potentiation or radiosensitization, I think we don't. The best answer is we don't know.
There could be a problem later because there seems to be, as best we can tell, a window after radiation where you get this radiation recall. And one more brief point, in tumors like this, we've sometimes seen dramatic regression of tumor, but then there are fistulous tracts everywhere. And so that's always a risk when you get this, and I think we've had 2 or 3 patients in that category. Ezra, you have too?
Yeah,
absolutely.
Marsha?
No, excellent point. So the patient did get postoperative XRT with continued pembrolizumab. Yeah. This was a CT scan 4 weeks into postoperative XRT. This is a relatively recent patient. He actually just finished his radiation therapy yesterday, so time will tell. Certainly we don't expect that this patient would be cured, but it's an interesting case nonetheless in terms of multidisciplinary treatment. Thank you all very much.
Thanks, Mark. That was brought up wonderful points, and you did it very rapidly, so really appreciate that. I want to thank the panel again for really a wonderful session. I wish I could bring you guys home to our tumor board on a weekly basis. Thank you to the audience for coming and attending. The panel is going to stay around for a little bit if there are any questions, but we'll move on to the next session. Thank you very much.